Welcome back to another episode of Change Talk. This episode we're going to cover diagnosis, where it comes from, what it's used for, and what to expect after receiving a diagnosis. Now keep in mind, the laws concerning most practitioners vary from state to state, and for the purposes of this video, we will most likely be talking about the rules and laws that govern therapists operating in the state of Connecticut at the time of making this film. Keep in mind, laws do change, so speak or find a mental health practitioner to learn more about this process. These cases that will be presented are hypothetical stories and do not represent any active or previous treatment attempts. Let's get started. Perhaps the first and most important secret mental health practitioners don't seem to tell some of their clients is, drumroll please, in order to get reimbursed by insurance companies, a practitioner almost always has to provide a diagnosis. That's right. Ever been given a prescription before, been evaluated, or seen a therapist before for treatment? Chances are you received a diagnosis and were not even aware that you received one. In most cases, as long as the practitioner has a valid and moral reason for doing so, a clinician has the right not to tell their client that they've made a diagnosis. That's right, you might have even received one of those labels before and didn't even know that you had one. There are actually a lot of good reasons practitioners make this decision. First and foremost, if telling a client that they have obsessive compulsive disorder is going to make them go to our diagnostic statistical manual of mental disorders and look up all the symptoms associated with the disorder, a practitioner might be justified in not telling the client. Can you think of a possible reason why? Well, for people that have obsessive thoughts and compulsive actions, what do you think giving a person like that writing down a list of symptoms is going to do? For those of you that answered that the person is likely to think that they have all of the symptoms, you'd be right. Other reasons why practitioners sometimes hold off telling a client that they have a diagnosis is that it is likely going to make their depression worse, interfere with future life goals, and the client may simply not be ready to find out that they have a diagnosis or acknowledge said problem even exists. Did you know that some life insurance policies, security clearance applications, and job forms asks you if you have a mental health disorder? What if you didn't even know you had one and you were filling out one of those applications? Do you think that would be for or against your favor? I'll let you be the best judge in this instance. The Diagnostic and Statistical Manual of Mental Disorders has been around for a very, very long time, originating from the early 1950s. The latest version, the DSM-5, was produced in 2013 and is continuously updated with new information and billing codes. Most recently, the DSM actually removed their old Roman numeral coding system in favor for a simplified numbering system that the American Psychological Association, who creates and modifies this document, is now acknowledging the likelihood of future revisions and has now added their new decimal system. For instance, instead of the DSM Roman numeral 5, future revisions would include DSM 5.2, for instance. It's also really important to realize that the DSM is not usually a method for identifying causality of a disorder. That's right. When you receive an anxiety disorder, for instance, that does not necessarily mean that it is caused due to something biologically inside of you. We call this the biopsychosocial model of treatment, since it is usually one or more of these categories that are affecting your overall mental health. Is there a DNA or biological marker for certain types of anxiety? Yup. Can anxiety be caused by people around you or your environment? You betcha. Is anxiety a symptom that can be associated with trauma or bad parenting practices? What do you think? So, with that said, two people with ADHD, for instance, could look very different depending on what's their major malfunction. ADHD alone has many theories behind it, from hemispherical imbalance in the brain, problems with the nucleus accumbens, misfiring of the corpus callosum, child of anxious parents, caused by previous trauma, a genetic link, your diet, delayed brain development, and the list goes on and on. All diagnoses are in a list of symptoms. If you have enough of these symptoms grouped together in categories called criteria, then congratulations. You are the recipient of your first official diagnosis. Please hold for applause. How about those people that say, well, I can't have PTSD since I don't have flashbacks or anything like that? Well, Hold your breath when I tell you that you can still be diagnosed with post-traumatic stress disorder, even without having that symptom. This is because most of the time, you, like most people, will represent a variation or special combination of these criteria and would still be eligible for a very sound diagnosis. The DSM is broken up into bigger categories called classes. They include classes such as neurodevelopmental disorders like autism, ADHD, and learning disorders. We also have schizophrenia and other psychotic disorders when a person generally suffers from a detachment from reality. Please do not diagnose your teenage child with this. Please don't diagnose your teenage child with this. Most of the time, it's part of their development, or what I like to call teenageritis. The bad decision making should pass. Hopefully. Next, bipolar and related disorders, where the client goes through cycles, sometimes manic and depressed moods. Depressive disorders that include many diagnoses affect your overall happiness. Anxiety disorders, OCD and related disorders, trauma disorders, dissociative disorders, somatic disorders, feeding/eating, elimination, sleep/wake, sexual dysfunctions, gender dysphoria, disruptive/impulsive/controlling conduct, substance-related, neurocognitive, personality, paraphilic, and other mental health disorder classes exist. There are actually around 265 current diagnoses in the most recent edition of the DSM. Some of the older diagnoses have been removed. Others were consolidated, and even more are currently still being investigated for inclusion. One of the most common errors that I hear from clients and their families is the use of improper or dated lingo surrounding diagnosis. The four most common includes attention deficit disorder, or ADD, which is now attention deficit hyperactivity disorder with a distracted, hyperactive, or combined subtype. Asperger's disorder is now Asperger's syndrome and is incorporated in our new autism spectrum disorder. Multiple personality disorder is now called dissociative identity disorder. And lastly, dementia is now classified under neurocognitive disorders. See? Thanks to this video, you can now blow the mind off your primary care provider or soon-to-be therapist with how smart and resourceful you are. Despite the very long history of having these categories that we place symptoms in, both the effectiveness and validity of diagnosis remains inconsistent. I joke around to my clients on a regular basis telling them that if you see 5 providers, you're likely going to get 2 to 3 different diagnoses. Especially like more severe diagnoses, like borderline personality disorder or bipolar disorder. It is sometimes hard to draw the line towards understanding what is a manic or intentionally destructive episode. There are a lot of things that get in the way of making a proper diagnosis. On a regular basis, clients are less truthful than what they should be. Yes, some clients do continuously lie to others about what's going on in their lives. However, it is more likely that the person the clinician is speaking to is either being influenced and clouded by their current symptoms and are simply not aware that a certain problem actually exists. Imagine a world you could identify your own maladaptive behaviors and thoughts. I'm pretty sure I'd be out of the job then if that was a possibility. Most of the time, this material is held at 3 levels. The conscious, where we're aware of what is going on. Subconscious, where we find it very hard to identify the real source of what is chipping away at us. Or unconsciously, where there are so many variables and barriers towards understanding ourselves that we are more likely than not to be aware of their existence. However, sometimes unconscious material will generally be corrected on its own as an auxiliary measure of standard psychotherapy. Remember, almost all behavior has meaning, although most of the time that meaning isn't at the surface. An example would be a child that is being defiant towards a figure of authority. Is the profanity or negative behaviors really the problem? Or is the desire for social acceptance and safety really what's driving those negative behaviors? You'll be surprised. Oftentimes in psychotherapy, problems get corrected without even talking about the problem. Sort of like a ripple effect, influencing things that were not intended. Alright, so diagnosis based off all these characteristics can already be a little clouded to begin with. Now, couple that with the fact that most practitioners are required to make a diagnosis within an hour and a half after meeting their client or patient for the first time? I don't know about you, but I don't go marrying a girl after the first date. That's considering the fact that marriage is no longer seen as being completely permanent, with divorce rates being what they are. Unlike the theoretical basis of a diagnosis, which sometimes resembles a sticky, gooey, and sometimes annoying substance you just can't get rid of. Fortunately, good clinicians use what is called a provisional diagnosis sometimes. Provisional meaning that the diagnosis is likely what is really going on. However, the provision being that it is not bulletproof as a standard diagnosis. Buying the clinician a little bit more time to try to be a little more systemic in talking to other professionals, perhaps visiting the home, talking to family members, or getting to know the client a little better. Another option clinicians sometimes use is attempting to use the diagnosis of adjustment disorder. That's right, if you're depressed or anxious, there might be an external trigger causing it. And when you remove the trigger, the symptoms you're currently experiencing are likely to go away. Generally, adjustment disorders don't really follow people around too much due to their lack of relative severity, and are understood by most of the mental health and scientific community as being situations that generally would lead a reasonable person to experiencing the same outcome as the person before him. For instance, you, just like me, are likely going to get bummed out if you lose your job, receive a physical disability, or have a death in the family, right? The trick is finding the right therapist that will take their time, do their homework, and will not inflate what is truly going on with you. The general procedure I follow when trying to investigate what is really going on for the first time is that I speak to a person's family member, then other professionals, and then finally speaking with the client to get their take of what's truly going on. Can you figure out why your spouse or brother might have a better understanding of what's really going on? And it has to do with that line thing we were discussing earlier. The importance of diagnosis surrounds helping other providers towards getting a brief little synopsis of what is truly going on, establishes parameters for treatment, gives direction towards what to do if medication is needed, and so on. In addition, a diagnosis typically might help indicate other things that are or have transpired in your life. For instance, a typical thing that we ask people that might receive a diagnosis of borderline personality disorder is that we ask them if there's been any sexual trauma in their past. Or a person suffering from hallucinations that has received a schizophrenia diagnosis if there have been any acute brain injuries in recent years. For autism, we ask things such as, do you have any cousins or siblings that are experiencing the same symptoms? How about people that you know have more than one diagnosis? If it is another mental health diagnosis, we call it a comorbid diagnosis. For instance, if you're suffering from one of those neurodevelopmental disorders, like ADHD, do you think that having potentially problematic brain development would likely cause any other symptoms? You betcha. It is very common for persons suffering from ADHD to have a comorbid diagnosis, such as social anxiety disorder and, later on in life, a substance misuse problem. It's just the nature of the beast. Did the now young adult choose cocaine to self-medicate his ADHD symptoms? Or is it because he is impulsive? Perhaps it was due to growing up in special education, feeling chastised, and became depressed as a result. See what I mean? When you see a substance misuse problem with a mental health diagnosis, we call that co-occurring or dual diagnosis. Lastly, and as a general rule in the state of Connecticut, only master's level or higher practitioners can conduct a mental health examination. This is due to a series of things clinicians look for when performing these various assessments, such as the Beck Depression Inventory or the Mini Mental State Examination. Everything you bring inside a therapy office is used as part of the assessment process. Your body language, the bags underneath your eyes, kind of like mine, rate of speech, voice tone, body posture, if you're missing any teeth, have you colored your hair bright orange, are you wearing revealing clothing, how do you act when you talk about your family members, micro expressions, do you smell like smoke or alcohol, and the list goes on and on. A clinician attempts to utilize all of your behaviors and appearances as part of the diagnostic process. How about that orange-haired girl that showed up to my office? Is she coloring her hair once a week just like she changes out her boyfriends? Or did she just come back from a Comic-Con convention and is idolizing one of her favorite video game characters? Despite one piece of evidence collected having very little relevance to anything, a collection of these pieces may indicate a potential diagnosis. Hence the reason why us professionals strongly suggest not web searching diagnoses you think your spouse has. And we encourage you to come in and see an experienced professional. A professional might even be able to tell you if problems in your relationship are pathology-based or due to differences in your personality. In addition, a professional will consider a whole slew of systemic measures to check your sleeping, eating, exercise, medication, social support network, and so on, to make sure your symptoms are not being caused by something else that potentially could be more or less serious, such as a thyroid condition or being hangry. That's all for now, folks. Stay tuned next week for a discussion on irrational beliefs, self-defense mechanisms, and internal family systems. Thanks for watching, and thank you for supporting Change Talk LLC.